Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Welcome to distant learning session of the Indonesian Society of Interventional Cardiology. Today's topic is a key concept to master bifurcation PCI. My name is A Fauzi Yahya, and I will serve as the chairperson for this educational webinar. On behalf of ISIC, we would like to thank to Abbott Indonesia, which supported these sessions. Dear colleagues, managing bifurcation PCI is always a challenge. It is not merely a choice between one stent or two stent strategy. Bifurcation PCI require understanding lesion anatomy, plaque distribution, the condition of side branch. The strategy must be planned with proper wiring, vessel preparation, and optimization steps, and also selecting the right stent design. Imaging is essential to guide the procedure and ensure a safe, precise final result. Dear college, in this webinar, we will review a clear and systematic approach to bifurcation PCI. Many of you may have joined other bifurcation sessions, but what makes this one unique is our focus on how OCT can get us to perform more precise and effective bifurcation PCI. But do not be concerned if OCT is not yet available in your daily practice. You don't have OCT in your cath lab. The principle you will learn from OCT can greatly enhance your angiographic intervention and improve your decision making, even when OCT is not directly used. So stay tuned to this session. We are very fortunate to have a distinguished faculty from Japan and our national faculty members who will share their knowledge and expertise to us today. First, I would like to introduce Dr. Noriaki Moriyama from Sonan Kamakura General Hospital. How are you, Dr. Noriaki?
Hi,
Yeah.
Dr. Fauzi. Nice to see you.
Yeah, please introduce yourself so our participant will know you.
Yes. Okay. Hi, everyone. My name is Noriaki Moriyama, interventional cardiologist in Japan. So I'm from Shonan Kamakura General Hospital. So I started my interventional program almost 20 years ago. So in the beginning, from the beginning of my PCA history, I completely focus on how to imaging the PCR OCT, how to use the OCT during the PCI intervention. So I have several publication regarding the OCT, especially in bioresorbable coronary stent, and how to optimize the PCI outcome. And then I focus on how to follow up the stent by using OCT at the remote phase. Nowadays, so my expertise has been widely spread. Now I'm one of the director of structure interventional cardiologist in my hospital. I focus on the TAVI procedure, and I have a 3 live demonstration of TAVI in Japan this year, and now I'm a director of cardiac implantable electric device such as a pacemaker and CLT, and now I'm managing the complete AV block after TAVI as a director. Thank you.
Oh, I see. Okay, thank you very much. It is good to have you here, Dr. Noriaki. Yeah. And we also join Dr. Nanda, who will present a challenging case for discussion. Dr. Nanda, please introduce yourself.
Hello, Dr. Fauzi. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Yeah, my name is Nanda. I work in National Cardiovascular Center Harapan Kita as an interventional cardiologist. Unlike Dr. Noriaki, I'm still learning just as a junior staff. And then now I'm taking the advanced fellow in coronary and also structural interventions in University Hospital of North Midlands in United Kingdoms. I'm still here. Hopefully I can finish this very soon in next February in 2026. So that's all about my introductions, Dr. Fauzi. Thank you very much.
Thank you. Welcome, Dr. Nanda. Dear colleagues, joining us three distinguished panelists. First, Professor Saifur Rohman, Senior Interventional Cardiologist from Brawijaya University, and Dr. Ilham and Dr. Ismir. Please introduce yourself from Professor Saifur Rohman first.
Yeah, thank you, Dr. Fauzi. Assalamualaikum warahmatullahi wabarakatuh. Nice to meet you all. My name is Saifur Rohman from Brawijaya University. Work as interventional cardiologist in Dr. Saiful Anwar Hospital. Thank you.
Okay. Yes, Dr. Ilham, please. Please unmute. Please unmute. You still mute.
Okay,
yeah. Good.
Good evening, everybody. Assalamualaikum. I'm Ilham Uddin. You can call me Ilham. I come from the Cardiology Hospital, Semarang, and I work in the Faculty of Medicine, University, Diponegoro University, and I work as interventionist, together with the same center with the Dr. Sodiku Rifki. Thank you.
Thank you, Dr. Ilham. Dr. Ismir, please.
Yeah, thank you, Dr. Fauzi. Yeah. Okay. Hello. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Dear colleagues, my name is Ismir. Now I'm working in the Dr. Eminus General Hospital Bengkulu and appointed as the head of the cath lab of that hospital. Thank you, Dr. Fauzi.
Yes, I would like to introduce that Dr. Ismir is acting as Secretary of Indonesian Society of Interventional Cardiology. So you have a lot of busy schedule, Dr. Ismir. Thank you very much for having you here. Yeah. So, dear participants, this session will last for 90 minutes. Following each presentation, we have a brief panel discussion and more comprehensive discussion will take place at the end of the session. So I encourage all participants to submit a question through Q&A box. You can just text in the Q&A box, and we will read and then let the faculty respond on it. Without further delay, let's begin with Dr. Noriaki Moriyama's presentation. Dr. Noriaki, please. Yeah.
Okay. Can you see my slide?
Yes, very clear. Yeah.
Okay.
Could you have a slideshow?
Okay.
Slideshow, yes.
Like
slideshow.
this?
Great, yes.
Okay, hello everyone. So firstly, I'm very happy to be here today. It's my great honor to speak here today. Thank you for our Indonesian Interventional Cardiology Society. So today's my topic is optimizing bifurcation PCI and OCT-Guidance. So today, firstly, I'm going to talk about why bifurcation PCI is challenging. Probably you can understand why bifurcation PCI is still difficult and challenging. And secondly, I'd like to share the evidence by using OCT regarding with our bifurcation PCI. And then after that, I'd like to share my daily practice case. So as you can see, the challenging part of the bifurcation is, I think this is we can summarize three parts. Firstly, bifurcation lesion has a very variable anatomy. This is a so-called anatomical complexity. we have so few reliable sizing and angle. And also we need to check plug distribution, and sometimes bifurcation has a true or trifurcation. And then next challenging part is our mechanical complexity. Sometimes we have encountered plug or clean shift after stenting, and we need to check stent deformation by using two-stent strategy. After that, what is best stent design is essential for the bifurcation PCI. So we need to decide provisional or primary two-stent based on the patient anatomy and the patient background. And also recently DK Clash has very good outcomes in the situation of a bifurcation PCI, but I think it depends on the patient anatomy. So we need to decide and several factors during the bifurcation PCI. This is the reason why bifurcation PCI is challenging. So I would like to summarize the recent reports. So as you know, in terms of a bifurcation PCI, a major cardiac advance event is higher than a non-bifurcation region PCI, especially in a larger amount of target vessel failure. And also, we need to care about the stent thrombosis in case of a bifurcation PCI. As you know, as you see the data in this slide, even in the early phase, so we have a significant difference of our target vessel failure and also stent thrombosis. Even after 3 years, we have a significant difference rate of TVF and stent thrombosis. This is our data from meta-analysis. And also, we need to care about early phase just after bifurcation PCI. This data clearly shows bifurcation PCI is clearly associated with a higher rate of adverse cardiac event even in the hospitalization phase. So as you can see, the MACE is higher than a non-bifurcation region, and due to based on the complexity of a bifurcation PCI, cardiac tamponade and all perforation complications are higher in bifurcation region than non-bifurcation PCI. So as you know, so recently, October trial has been published. So in my center, OCT has been available since 2000, probably 2011. So at the beginning of the OCT using, so that was just research too, but we have been, in my center, we have been using almost all OCT, we applied OCT for almost all cases of PCI. So this trial clearly shows superiority of OCT-guided PCI in bifurcation region versus angiography-guided PCI. So primary outcome was composite outcome, including cardiac death, target lesion myocardial infarction, or ischemic-driven target lesion revascularization. As you can see, the OCT-guided PCI was significantly associated with a better outcome in the primary outcome. And also, if you see the secondary outcome, all-cause death was numerically lower in the OCT-guided PCI group. But as you can see, the in terms of stent thrombosis, there was a significant difference was observed in the stent thrombosis. And if we see our subgroup or insight, so clinical benefit OCT-Guidance PCI was consistent across subgroups, including left main bifurcation lesion and both provisional or two-stent strategy groups. And also this data included a highlight over high complexity lesion types in this trial. However, our main result was consistent even in the high complexity lesion types. It means this data clearly shows we need to use imaging device, especially OCT, for our bifurcation PCI in the daily practice. And also, this is a meta-analysis data. So this meta-analysis included 5 randomized clinical trial. This meta-analysis clearly shows superiority of our OCT-guided PCI for bifurcation lesion than angio-guided. OCT-guided PCI was significantly associated with lower all-cause mortality and lower cardiovascular mortality and lower target region revascularization. So, as you see the data, so in this field, we must use dual antiplatelet therapy for the all PCI. I think dual antiplatelet therapy is a must for PCI. And also based on this evidence, I think OCT-Guidance is also must for the bifurcation PCI. But in my experience, so in the beginning of the experience about OCT-Guidance of PCI, so probably everyone had some concern about interpretation of plaque morphology. But I would like to recommend you to simplify the interpretation, such as soft or hard. Of course, a hard plaque has including calcification and also very thick circular or fibrotic plaque, and the other is all of others are I think divided into the soft plaque, and we need to we need to grade the risk of cleaner plaque shift during OCT-guided PCI. This data clearly shows how is the risk of plaque shift or cleaner shift. This is almost the same to our angio-guided PCI, but this data is easy to understand. If we have a very short side blunt distance, so risk is plus 1 point, and also our longitudinal length of side blunt distance is over than 1.3 meter. So this is the risk of shift. And also our parallel type, it means this is a very shallow angle of bifurcation. This is a risk of cleaner or plaque shift leading to the occlusion of side branch. And in this session, probably I would like to mention about 3D OCT. So I think 3D OCT is very reliable to check the wire position in the at the ostium of the side branch. However, in the real world setting, if you have OCT in your daily clinical practice, sometimes 3D OCT is time consuming. But nowadays, visibility of OCT is rapidly improving. If we're using 2D OCT, I think it's enough to check the wire position at the ostium of side branch. And also, we need to consider about the stent position. So this is the most important part of PCI, I think. So even in the non-bifurcation lesion, stent malposition is clearly associated with the target vessel failure. So we need to check the stent position by using coronary imaging, especially in the OCT. I think OCT is the best to validate the exact stent position. So this data clearly shows where is the risk of stent malposition. So this data clearly shows our main branch has a good apposition because of the balloon dilatation, and the pot technique is are very easy to be applied. But as you can see, the side branch side, even in the proximal side of the main branch, as you can see, the slight malposition was seen, and also at the ostium of the side branch, stent malposition frequently happened like this. And actually, in my daily practice, I use OCT very simply. And also simplify the OCT guidance PCI is the key to successful and bifurcation PCI and keeping the better long-term outcome, I think. So I would like to recommend a 3-step with a single or standing method. Of course, this method is depend on the patient anatomy and also complexity. Firstly, I prefer to put OCT and detailed analyze with using first OCT polymark. I would like to see the bifurcation angle and also side branch ostium dimension. And also, we can decide old strategy. I will show you my strategy by using OCT later, and we can decide stent landing zone, and also we can decide balloon sizing and also stent size and length by using first OCT polymark. And after that, probably all of people nowadays doing the pot technique of the proximal of the main branch, and then all of our interventional cardiologists will lost the wire. And then I would like to recommend the second OCT polymark to check the wire position. And also we can see the position of the stent. And then we can decide to do or not the KBT. And then final polymark should be performed. And at this phase, we need to check also stent malposition and deformation, and also we need to check the edge dissection and so on. And so I'd like to share first case. This case was performed 1 year before, 1 week before. So this is clearly, this angio clearly shows the left main bifurcation lesion. The patient is a 70 years old male with a moderate chronic kidney disease, and the patient referred to my hospital with unstable angina. So firstly, I put the diagnostic catheter from the right lateral artery, and I confirmed the lesion, and I use 6-French ABU because there's no significant calcification by using angio. And my strategy is two-way strategy in LAD and left circumflex, and this is a unstable or angina patient. So first OCT pullback was performed after small size ballooning. This is the first pullback OCT. So I'd like to show you in detail. This is a left main, the proximal to the lesion. You can see the calcified nodule. In this slice, we can see the belly widely open the left main coronary area. Area is over 5. So probably we should not touch in this situation because this is a patient with unstable angina. So in my strategy, at this moment, I didn't touch this calcified nodule. So I would like to continue review the OCT. We can see some calcification, but it's not superficial and very small calcification. So this is not hard plaque. We can easily modify this lesion by using balloon. And also we can see the lipid-rich plaque covered by the very thin fibrotic plaque. And then this is a true lesion, true left main lesion. And the plaque morphology is fibrofatty tissue. So this is actually soft plaque, and the lesion is actually very short. I do not think this lesion has risk of no reflow, because the lesion is very short. And this is a bifurcation lesion. As you can see, this is a not parallel type. So, of course, and also if we look at our angiogram, so our bifurcation angle is very wide. And as you can see, there is no significant plaque at the ostium of the left circumflex. There's a little risk of side branch occlusion, and also there's a very small risk of plaque or Carolina shift. And this is the ostium of LAD. This is clearly a soft plaque. And there's no significant calcification, but we can see deep calcium here. But we need to decide this calcification at this moment. And this is our detailed analysis slide. So this is a proximal left main. So we can see calcified nodule. So vessel size is very large. Probably we cannot modify this calcified nodule. So I decided not to touch in this session. Probably this is near the landing zone. So, and also with using OCT, longitudinal assessment is very important. So firstly, I decide this lesion could be the proximal landing zone, because this is not this lesion doesn't have any lipidic plaque. There's a small risk of coronary dissection, edge dissection, and this is lesion. This is a very soft plaque. And also, this is a ostium of a left circumflex. It's widely open. And also, this is a ostium of LAD. And it should be the distal landing zone, because the landing zone should have the stable plaque, because there is a small risk of coronary dissection. And I decided to put a 30 millimeter stent. And also proximal landing zone reference is a maximum 3.6 millimeter. And the distal landing zone vessel diameter is around 3 millimeter. So first interpretation by using first OCT. So landing zone assessment is very easy. So I did not touch the calcified nodule at this moment, because the risk of stent malposition. And landing zone size is 3.5 millimeter. And this landing zone plaque seems to be fibrotic tissue. There's a less risk of edge injury. And the landing zone stent size could be the 3 millimeter. And the bifurcation assessment, low risk of compromised left circumflex ostium. And the lesion is a fibrofatty plaque to short lengths of thick fur. We do not need to use our debulking device. And then we can assess the calcification. Calcification volume is very small, and also calcification is not superficial. So based on the first OCT probe, my procedure planning is firstly, I use a 3 millimeter non-compliant or cutting balloon for left main to LAD, and 3 millimeter or 3 by 30 millimeter depth for left main to LAD, and pot with 3.5 millimeter non-compliant balloon for left main to obtain the good apposition, and then regloss the wire for left circumflex and check the second OCT. And we need to decide KBT if needed, and then a final OCT should be performed. This is our stent implantation. This is our stent implantation following 3 millimeter cutting balloon inflation, and then we did a pot with 3.5 millimeter non-compliant balloon, and then I did a second OCT evaluation. So we can see the proximal stent landing zone. So stent was clearly put just distal to the calcified nodule. Still, we can see the small malposition. Probably we need to do more aggressive pot. And we can see the left wire towarding the left circumflex. So I continue the OCT. So stent position in the left main is very good. I'm sorry. Is very good, I think. And even with the 2D OCT, we can see the place of the wire position. I think wire close the distal part of the side branch. I think this is a very good sign. And this is the exact appropriate place of our side branch wire after pot technique. And I will show you the distal part. Stent position is very good, and there's no complication at the distal part. We don't need any touch for the distal part of the stent. And I decided to the KBT to optimize the stent position. And for the our future intervention for the left circumflex. And then final OCT was performed. So we can see very good deposition in the left main, even with the distal part of the LAD. And this is the final angiogram. Procedure time is just 40 minutes, and the contrast dose is just 100 later. There was no procedure complication. So my take-home message was, I think OCT-guided PCI is superior to angio-guided PCI in bifurcation region. And I would like to recommend you to first OCT evaluation in detail is very essential for our deciding and planning the bifurcation PCI, and we can decide everything based on the first OCT evaluation. Probably based on the previous data, we must use OCT for PCI in complex regions such as bifurcation. Thank you for attention.
Thank you very much, Dr. Noriaki. Very excellent lecture. It is good to have you with a huge experience with using OCT, and you mentioned that most of the case in your center using OCT guided PCI, and you starting using OCT since 2011, which is almost 15 years.
Yeah.
And it is really a provoking case to discuss. In which you show us there is no non-eruptive calcium nodule at the left main with large lumen size. And during left main PCI, you did not want to touch these kind of lesions. And instead, you just put the 30 millimeter stent, just distal part, and open up using 3.5 non-compliant balloon, and end up with the kissing balloons. So I'll invite the panelists and to discuss about what the Dr. Noriaki already presented to us. Dr. Ismir, can I ask you how is your daily practice in dealing with the bifurcations? Is it any difference or how? Please.
Yeah. Thank you, Dr. Fauzi, and also thank you for Dr. Noriaki for the great lecture. In my daily practice, I think that for especially before calculation in the left main, firstly that we have to consider about the morphology and anatomical of the left main bifurcation. So we should consider by angiographically data that we kind of use of the ABC criteria of left main bifurcation, such as the angulation and also the side brain size, and also the minor criteria that we have to consider whether we should do only simple PCI like what Sensei Noriaki doing that might not compromise if we just put a provisional stenting. So I think that the first angiographically evaluation is important. But I think the criteria from the angiography also is not really enough. Sometimes we can see that maybe there is a true bifurcation, but we need more deep insight using the intravascular imaging. Maybe we can use IFUS and others OCT. In my cath lab, I have only IFUS right now, so I didn't use OCT for evaluating the left main bifurcation. But I think because that the OCT is come later rather than IFUS, there's so much data about the left main intervention that using IFUS, but the latest data also shows that the OCT in the left main intervention is also as good as the IFUS, like Dr. Noriaki did in his center. By using the intravascular imaging, I think it is mandatory to do that. But I would like also ask Dr. Noriaki maybe about his experience. We have know that the IFUS have so much um, uh, clinical evidence, and also the OCT also have a better in luminal image precision, like you mentioned, and also it's maybe better in the calcification rather than IFUS. And but in kind of the ostial Leishman lesion, do you also use the OCT for guide your PCI, because you always use the OCT. Whether we know that there's one of the limitation of the using OCT in the Leishman. I think that's the first point. And then the other thing, I think that what you are uh, giving the lecture about the OCT risk of the risk score for the carina shifting is very helpful for us to whether decide in the first step we are going to put a stand strategy or only provisional stanting. I think that the score is very helpful. Thank you, Dr. Fauzi, and maybe Dr. Noriaki would like to answer my
Okay,
question.
Dr. Anyaki, please respond regarding how the OCT role in the osteal disease, which is in the aortic osteal. I mean osteal. Do you use it OCT in the aortic osteal disease, which involving aortic osteal disease? I mean, please.
Can I talk?
Yeah, please.
Yeah. So probably 5 years before, I tried to use OCT even with osteal lesion, but as you know, it's very challenging. But some specific if we use some specific guide extension, we can see the outside of the guide extension. With using some specific guide extension, we can clearly see the osteal lesion by using OCT, but sometimes it is very difficult, So, and also one other drawback of OCT is CKD contrast problem, and also another other thing is long lesion and very hard or calcified long lesion. So sometimes OCT didn't pass. That was a limitation of the OCT, I think. So nowadays, I don't use OCT for osteal lesion. IBUS could be better. IBUS is clearly better, I think. This is a drawback.
Okay, thank you very much. How, Dr. Ilham Uddin, any comment regarding the lecture of Dr. Noriaki? Please unmute.
Okay, thank you. And your center is using OCT as a daily practice for daily practice into intervention. How about in the patient with the renal function was decreased, and we want to limit it using contrast for two procedures? Mostly is one study picture with the OCT is very clear with the contrast, but sometimes we must using another liquid to change from the contrast to preventing occlusion. Do you not using another liquid to producing a picture of the OCT?
Yes, thank you. Thank you for our question. This is very important. So, as I said, one of the problems with OCT is the contrast volume. So in my center, sometimes I use our dextran to eliminate blood cell, and also if we have the belly or straight vessel and also proximal lesion, we can see the clear clear picture by using normal saline. this is one of the option, I think, dextran or normal saline flush. This is enough to eliminate the blood cell to get the clear vision. Yeah.
Okay, thank you very much. Dr. Saifur Rohman, please.
Yeah, thank you. Konnichiwa, Dr. Noriaki Sensei.
Konnichiwa.
Konnichiwa.
Please speak in Japan, maybe,
Yeah,
because
please.
Professor Saifur Rahman got a
Zenzen
PhD in
wakarimasen.
Japan.
It was actually a very nice lecture.
Mm.
In our center, we use only 10% of imaging and only half of them, I mean 5% using the OCT. In our daily practice, it was actually difficult to distinguish calcified nodule without imaging, isn't it? Somehow we also noticed that I have one case with the ATS non-semi, and then I heard I thought that this is actually not calcified really, but I just putting a stand, and then ISR happens. After that, we did with a confirming of the OCT, showing that it was attached the calcified lesion, which it causes malposition. This is why my our very thoughtful case. I mean, in your my daily practice, because of not routinely use the imaging, how actually can we distinguish roughly with the angiogram whether this is nodule or not, calcified nodule or not? This is actually maybe you have any suggestion. The second thing is actually you just perform the professional stance in it. Then the another issue is rewiring. Which part the best part, in my opinion, I like to just rewiring from the distal part of the carina by using the angiogram. But I thought that using the OCT, you might also appreciate and more precisely choose the rewiring through the through of the distal part, isn't it? What do you think?
So I think that's a very good question. So you for your first question, so I believe so angiogram is the best for the PC operator. This is our basic for everyone. But sometimes angiogram tell a lie, because we cannot distinguish the thrombus or calcified nodule. So this if we use angio-guided PCI, so patient history is very important because that was our ACS or chronic stable angina. Probably our ACS has a more risk of thrombosis. But if we use our OCT, if we use IBUS, we can easily distinguish our thrombus or calcification. And as you said, so with using OCT, so our differential diagnosis of our thrombus and calcified nodule, it's sometimes difficult. We need some experience, because elective type of calcified nodule had some thrombus at the superficial of calcification. So in this kind of situation, so we need to check the plate shape calcification at the end of the nodule. If we see the platelet seat type calcification, so this probably this nodule could be the calcified, because calcified nodule is made by the coronary motion and clogged by the calcification seat. This could be the calcification nodule. So as you said, even with using the OCT, differentiating the calcified nodule, or some type of calcified nodule and thrombus required some experience of interpretation of OCT. And the second, for your second question, wiring position is very, I think, very important if we use our decay clash or two-stent approach. But nowadays, in my center, complex two-stent strategy is, I think it's very rare. And also, if a lesion is located at the distal part of the LAD, so as you know, the OCT is sometimes very stressful, you know. Wire position should be checked only in case of the left main bifurcation. This is critical, I think. Yes.
Thank you.
Thank you very much.
Thank you.
Thank you very much. It's wonderful question and answers. So there is two questions by the participants. This is interesting questions. First is whether the distal crossing wire in which is acute ankle anatomy, whether this is the right method, because mentioned by Dr. Bayusi, if you are wiring the distal crossing, mechanically pulls the strut outward and then creating protruding long metal carina into the main vessel. What do you think about these questions? He's asking that when there is a narrow angle, whether this is the right method to crossing to the distal part.
I think this is very good question. So if we use a 3D OCT construction, so we can clearly see the where the wire pass our stent strut, but so in the proximal region of bifurcation, such as the left main, so bifurcation angle is ordinarily very wide. Probably this situation could be happened in the LAD and the second dive now like this. So maybe creating a proton long metal carina into the main vessel. Probably this is a very difficult question to understand.
Yeah, usually when you are wiring the proximal part, there's going to be protruding long metal carina. But in the such a narrow angle, I don't think that is going to protrude the long metal carina when you are wiring to distal part.
Maybe for the all of bifurcation, probably we should close the wire distally. I think this part. This could be the good best. I think.
Okay. And the other one is the late catch-up thrombosis. Whether this is caused by excessive metal overhang. Because sometimes the excessive metal hang because no kissing balloon, and then still overlying metal hang in the ostial side branch. Whether this causes the thrombosis?
Actually, so I do not have any thrombotic problem during the PCI situation, but sometimes I think protruding metal stent at the side branch ostium could be the risk of thrombosis. But nowadays, stent design itself is improving. So, and stent thrombosis is very rare.
Dr. Bayusi mentioned when you are not removing the strut in the ostial side branch, it could be induce the thrombosis. That's why lead catch-up thrombosis may it happen due to excessive of metal in the ostial side branch instead of under expansions.
Yeah, I think it's true.
Yeah,
but
yeah, I think so.
Yeah, I think so. Yeah.
But I think the under expansion is playing a role as well, especially maybe bigger role in the instant thrombosis. Yeah.
Yeah, true.
Okay, and then the brief response. Looking at the angio that you are showed to us in the case, we don't see any calcified lesion. Dr. Bambang mentioned in the text. But the OCT showed non-eruptive calcium nodule. Do you think that CT scan beforehand may help to define landing zone if OCT is not available?
Me?
Yeah.
Yeah, probably if I did the angioguided PCI, so landing zones could be more proximal, I think.
Yeah, I think so. Yeah, I think so.
And also I select more larger stent.
How about CT scan will identify this kind of calcified nodule?
Sometimes we can identify calcified nodule, but with using the 3D image, still it is hard to exactly identify the calcified nodule, I think.
Okay, thank you very much. So thank you very much, Dr. Narike, for your presentation. We are moving forward to the case presentation by Dr. Nanda. Please, Dr. Nanda.
Okay. Thank you very much, Dr. Fauzi. Can you see my slide?
Yes,
here?
of course.
Okay, thank you very much, Dr. Fauzi. Again, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, chairman, panels, and all the participants. Thank you for Isaac for having me. I'd like to share a case about the left main to LAD diffuse disease and how this anatomical complexity really shapes our clinical decisions making. So this is the patients that I'll be presenting today. He is a 70 years old former military officer who has been experiencing angina with mild exertions, which has gradually worsened over the past few months. He is also hypertensive with high cholesterol level, normal renal functions, preserved ejection fraction, no valvular diseases, and how his exercise stress test by the treadmill test was positive for inducible ischemia, which prompted further invasive evaluations. Resting ECG show no abnormalities. Although the resting ECGs was normal, the findings of the treadmill test were very clear. By the 4 minutes into the test, patients developed a clear angina, very typical, accompanied by significant ECG changes, which is consistent to ischemia. So given the previous findings, the data about the clinical, also the supporting examinations, we went to the coronary angiogram. And from this cranial view, it is shown that there's a diffuse disease in the LAD with a possible left main involvement from this cranial view. So if we look at the caudal view, the circumflex artery does show a few areas of angiographically significant narrowing or stenosis, whether it's in the LCX or circumflex main branch or the OM branch. Meanwhile, the RCA looks dominant and it clearly has some mild disease proximally. Therefore, we calculated the anatomical syntax score was about 29. So to summarize the angiogram, there are a few findings here. First, we have diffuse disease in the LAD with a possible involvement of the left main. And the second, there are also several angiographically significant lesions in the circumflex artery and also the OM branches, while the RCA appears non-significant on the angiogram, and it's a right dominant vessels. So I will hand over to the chairman and the panel for their thoughts. Thank you.
Okay, thank you very much. So let me first ask the Dr. Ismir, what would you do in this kind of left main and LAD diffusely disease? Would you
Okay.
treat directly, or whether you need some sort of other
Yeah.
diagnostic modality?
Yeah. Okay. Okay. Thank you, Dr. Nanda. Can you show the previous angio? Maybe still picture is okay. Yeah, this
Yes.
one.
Oh, okay.
Yeah. Okay. My appreciation to this angiographic data that maybe what Dr. Nanda says, that's a diffuse disease and the LAD meet until the ostial part. And if the ostial part is disease, so we can consider there is also involvement of the left main. And then we can see that the left main is not very long. And then the circumflex also may be diffusely diseased from the proximal to the big OM. But what Dr. Fauzi mentioned, should we do this directly? I don't think so. This is a complex coronary angiogram. So we need more data, whether we have to decide what should we do in this part of complex long lesion. Maybe other consideration, keep it still the option, but if it is not approved by the patient for the KBIS, I think that we have to really careful whether we should put a very long stent in the LED or the circ, and also goes to the left main. So we need more data. We might need IFUS. I think that imaging is very important in this case. And then if you want to decide whether how long the part, we can also use the imaging using OCT or IFUS, and maybe we need others to see whether that is it both of the vessel, like the circ, is it very produce the ischemic? Maybe we can consider using physiology data, Dr. Fauzi.
Okay, you mentioned about the physiologic data. The patient already have a treadmill test, which is show the positive result.
Yeah.
Should we use a functional test for such a case?
Yeah, I think there's still a room, even that the non-invasive shows there is ischemic, but because this is a very long lesion, so there is another that we can have by using the physiologic data, whether that this is a focal lesion, even that we can see this is quite a diffuse disease. But if there is some focal lesion by the angiogram data, that we might not willing to put a very long stent in this kind of lesion, Dr. Fauzi, and might be make our job easier.
Okay, maybe this is the in functional significant. Doesn't it put us to decide to intervene if there is a significant? But maybe functional test give another data about that. Okay, let's see. But let's make a decision that the patient need interference. Dr. Ilham, how to prepare the lesion for such a case?
Yes, well, first we assess the coronary is very complex, and there is many side branch significant. First, we're thinking that maybe there is bifurcation problem in the left main, because the non-invasive treadmill test show that there is AVR increase elevation and precordial extirpation until the lateral. But the angiography, there is a diffuse and side branch is maybe need the bifurcation, non-left main bifurcation in the diagonal 2, because the diagonal 2 is maybe the gate size is 2 or more, then there is a critical. And then in the second, the left circumflex, there is OM2 is so big, but the distal of the LCX, there is a slightly tight. So if there is, we're thinking about maybe, I think that there will be have two problems. The first, the bifurcation problem in the left main bifurcation. The second is maybe a bifurcation in the diagonal 2 or M2. And so why we need the, because of there is a diffuse the LED, and there is a potential compromise the diagonal 2, we need the to physiology study wants to know there is a pressure jump in the one of the stenosis in the LED. Then we can to certainly there is a need the bifurcation for the LCX, bifurcation left main. We need the functional test 2 to the LCX. So after that we can prepare to preparation, because after we know there's a need bifurcation left main, we need the guiding bigger about the 7 frames, and maybe need the slender sheet in the 4 radial, and because we need bifurcation left main need the before kissing balloon or pot, we need the bigger balloon for the pot.
Would you would you use a regular balloon to prepare the lesion, or your specialty balloon like cutting or scoring, or whether you need atherectomy or
first,
IVR maybe?
I think the first we determine is the problem is the LED. If we find there is a pressure jump in the one of the lesion,
okay, yes,
we not need the then we need the imaging. The needs imaging to certainly is there is calcification or not, because from the angiography only is there not clear the calcification, but sometimes for the imaging will be detailed. There is a kind of the moderate calcification with the fibrotic and others, so we need scoring balloon or just a balloon only.
Okay, thank you.
Okay.
Thank you. Professor Saifur Rohman, what kind of imaging that you are select to tackle this lesion? And when you are selecting OCT, how you use it? What kind of information that you are going to have it before putting the gear?
Yeah, thank you, Dr. Fauzi. Of course, considering that this patient has been suffer from the hypertension and also the elderly, which is known to be suffer from the medial calcification, and secondary, we also appreciate the long lesion with a distal run of quite good. It means this actually need the OCT in my preference, because the OCT might appreciate the thickness of the calcium, and then for the hypertension, the calcified of medial layer could be appreciated by the OCT. You might also appreciate that as comparing to the distal run of the left main quite the same. It means I saw that it seemed that this left main supposed to be bigger than our visual imagination. And then we could again and obtain the score of the OCT, not only the thickness, but also the circumference and also the length of the calcification. This is my opinion.
Yes, yes, yes. And also identify the landing zone, right? The distal landing zone. We don't know exactly whether this is diffusely disease.
Yes,
Yeah,
exactly, exactly. Because because it's very
yeah,
long, and if it is
yeah.
in long lesion, it is difficult for us to decide the landing zone.
Yes, yes.
Thank you.
Dr. Noriaki, this kind of short left main, would you still using the OCT for such a kind of disease?
I think OCT is still acceptable for this kind of lesion. I think we can clearly see the left main body, but as you know, osteum, exact osteum is challenging. So in this kind of multiple or vessel lesion, if left circumflex doesn't have any functional ischemia, I will do the OCT guided LAD to left main PCI if our myocardial ischemia is positive in LAD, but both LAD and the left circumflex has myocardial ischemia with using functional test, and also patient prefer to do the PCI. We should do the PCI probably only one session for the both coronary artery. Honestly speaking, in this kind of situation, I will use IVERS because of the concerning of contrast, I think. Yeah.
Okay, how about you think that you need a functional test for this kind of disease, or whether you are already have convinced that this is ischemic, the LED, I mean the LED territory. Do you routinely use a functional test for such a case?
Yes.
Okay.
In my center, routinely perform. Yeah.
Yes. Okay. Let's Dr. Nanda, what you did.
Okay. Thank you, Dr. Fauzi. Can you still hear me and see my slide?
Yes.
Yes.
Yeah.
Okay,
We can
great.
hear you clearly.
Thank you, Dr. Fauzi. So, yeah, based on the information so far, our aim is to keep the approach as simple as possible for the patients. And geographically, the diffuse LAD is clearly significant with likely left main stem involvement. And what we really wanted to understand was whether there was any focal disease along the LAD to the left main, or whether this was a diffuse disease throughout, all the way from the left main to the mid LAD. As the management strategy, would be quite different between the diffuse and focal disease. And as expected, the LAD FFR was significant, 0.71.
Yes.
And the FFR pullback here, we also did the FFR pullback to measure whether there is any significant focal or just focal disease, or this is a long diffuse disease throughout the left main to the LAD. And we observe a diffuse pressure drop from mid LAD all the way back to the left main. So it's clearly a diffuse disease in this kind of LAD. And then we also performed the circumflex FFR. We also wanted to assess whether the circ was truly significant. And if the circ is not significant, this would allow us to keep the procedure much simpler, I think, just focusing on the left main to LAD PCI without touching the circ. Then we therefore place the pressure wire to the largest branch supplying the largest territory, which is this branch, the biggest branch here. The FFR was 0.83, indicating it's a non-significant disease in the large OM branch. We didn't put the pressure wire to the small circ here, even though we can clearly see there's a tight stenosis, as we presume that this territory will be supplied also by the distal of the RCA, which is significant. Okay, Dr. Fauzi, do you want to discuss up till here, or?
No, just proceed
okay.
until we got the OCT finding.
Yeah. So to optimize the PCI result, we use the intracoronary imaging devices, in this case, OCT. On the OCT, we could clearly see mixed plaque morphology. Here, I will slowly move the cursor with the fibrocalcific disease here. We can see here calcified in the mid-LAD with a predominantly more fibrolipidic near the left main, also the ostial of the LAD. The lesion was quite long, as we expected, from the left main to this area, to the mid of the LAD. This is the healthy part of the LAD. Okay. Yeah, approximately, this is the more in detail. The size of the left main was about 5 millimeters. The ostial and the proximal LAD was around 3.6 to 3.7. Maybe we can downsize the stent about 3.5, while the mid LAD was around 2.7 here. So yeah, this is the very tight lumen in the mid of the LAD here, just after distal to the diagonal too. And also, we also performed the OCT to the circumflex area to assess the risk of plaque shift into the circ during the PCI to the left main LAD, and also to see whether there was any significant ostial circumflex disease here. Yeah, there's a lot of calcifications, as you can see, Dr. Fauzi and all the panels. Yeah. It is more in detail. Yeah, we know that it's interestingly that the OCT of the circ is actually suggested more extensive calcifications than in the LAD. Especially in the proximal segment and a relatively small lumen area in here, for example, is just 0.85 millimeter square. However, the circ ostial diameter here is remain reasonably large, I think, with only a minimal disease in here. Okay. So again, yeah, I will give the time to the chairman and the panel to discuss the findings and the next possible strategy. Thank you, Dr. Fauzi.
Okay, a very good diagnostic. So you already using the functional test and showing the pressure jump. So what do you think if there is no pressure jump? This is a significance, but no pressure jump. What will you do?
Are you asking me or?
Yeah.
Oh, okay.
I am asking you.
Yeah, so I think because this patient has a lot of symptoms, and then we can see that there is the left main disease as well. I think I will proceed with the PCI regarding this patient has no diabetes mellitus. So I think we can still see some benefit to do the PCI in these patients. And after we assess the circ with the FFR, I think we don't need to touch the circ. So the syntax score from 29, maybe we can reduce that anatomical syntax score to the functional syntax score. So I just calculated the functional syntax score is about 21 after we assess the significance of the circumflex using the FFR.
No, I mean that you already measure FFR in the LAD territory, and there is a pressure jumps. That the reason that we can treat this, but when there is no pressure jump, diffusely disease, this is significance, but no pressure jump.
Yeah, I think it's still under the it's very debatable, Dr. Fauzi, because in this kind of patients with a significant symptoms, and I think I will treat these patients with a diffuse disease, and we still have some good landing zone in the distal. So
yes,
in case the patient need CABG later in this life, maybe the patient still have a chance for CABG in case of ISR or whatever it is in the future.
Okay, keep your strategy inside. So let Dr. Noriaki, what's your strategy when you are dealing with such a functional test?
Yes, this is actually a very good case and very tough case. So if FFR is negative in lady. At this moment, I didn't touch for this lesion because FFR is negative. But probably I will try another functional test, such as the scintigram, to see the to evaluate myocardial ischemia, and also if patient have a significant symptom. So probably maybe it's a very difficult situation whether we should treat patient or not, and what kind of a treatment should be better or not. If patient have a stable angina, so firstly I will do the OMT, and then I will check patient symptom. Even after OMT, I will do the I will recommend patient the PCI or CABG because of our diffuse region, and also it's very difficult to identify the significant region, I think.
Yeah,
but if we do the PCI, if we do the PCI, so there's no or calcified lesion, so we can we will clearly open the vessel by using the only ballooning, and procedure itself is very easy. But if we have a significant ischemia even in the left circumflex, so strategy could be the probably complex, I think. Yeah.
Okay. So do you think that when this significant FFR but no pressure jump, you think OMT still play a role with such a left main disease? Or you are thinking that this is better to send the patient to KBH or doing other option strategy? Dr. Noriaki. I mean, that's functional, but no pressure jump. That's question, because this is diffusely disease.
Probably, I think at least LAD has a ischemia by using functional test.
Yes.
But functional test didn't show any jump up. It means we cannot identify where should be treated by using PCI. Probably in this kind of situation, I think yes, honestly speaking, CABG could be better, I think.
Okay.
Yeah, I think.
Okay, thank you very much. So any other comment from the panelists regarding your strategy after having such a diagnostic functional test and the OCT? Please.
Dr. Fauzi?
Yeah,
Ilham?
please. Yeah, please, Dr. Ilham.
Okay. From the FFR, there is still normal, but there is a pressure jump because I think there is a diagonal one is very big, and there is flow will be going to the diagonal one. So why the first examination of the FFR is still normal, but after the diagonal one there is significant pressure jump, and there is significant stenosis. It means there is a burden of the ischemia. But the diagonal 2, there is a very critical osteal. But from the IFUS, I see there is a fibrocalcified moderate to mild, and maybe intervention. There is a part is only focal to treat by the predilatation, then the DCP, because we concerning after maybe in the next day there is need a revascularization for KBH. We still get the putting graft in the distal of the LAD. Concerning the left circumflex from the FFR is still normal. But for the OCT, maybe there is osteal problem, slightly fibrocalcified, and if we're thinking about the potential to treat the left main, although the FFR, the LAD is still normal, maybe will be becomes shifting shifting plug or compromise to the LCX.
Yeah.
So we must be concerned the bifurcation left main procedure if there is a thinking about to do intervention to the left main, because the patient is the symptomatic and the treadmill test in the moderate exercise there is a ischemic very large in the precordial anterolateral. It means this patient is still needed to intervention if there is a optimal treatment have been achieved for the anti-ischemic. Thank you.
Thank you. So a brief questions. Whether you put all the way the stand from the distal part to the left main, or two stand, one stand, or what your strategy, Dr. Ilham?
No, it's for I just thinking about the because left main is a very large territory, about the 70%.
Yeah.
So why we thinking about the intervention only the left main, but the distally there is a problem of potentially shifting as compromise the diagonal one, diagonal two. So we only the ballooning and then DCB only in the mid of the LAD. Just putting bifurcation procedure only in the left main.
So just putting the short stand the left main proximal LAD. You think that?
I don't think this procedure may be needed bifurcation procedures because
you think you two stand technique, you mean?
I think yes, because from the angiography there is the size of the left main is almost the same with the gating. It means almost 2 millimeters, but the normal left main is about 4 or more than millimeters.
Yeah. Of course, the left main is already diseased, but you would you put the stand two stand to the LCX and the left main, or just single stand from the left main LAD?
Professional stand.
Professional stand.
Yeah, maybe from the Nanda says that the potentially the occlusion of the LCX. If we're thinking that the procedure will be make a compromise to the LCX, so we're thinking the upfront to stand strategy. But if we didn't think, because the set branch LCX is so big and there is big enough, and I think it's didn't potential to shifting or compromise the LCX. So only the professional standing for the LAD to LCX from the left main to LAD, just putting only one stand, then port to the left main, and then the access to the side branch, then evaluating is there any problem to the LCX or not.
Okay, thank you very much. How about Professor Saifur Rohman? Would you use a two-stand strategy, considering there is huge plaque burden, the ostial circumflex, despite there is normal functional test, or would you just professional standing to the left main LAD? And how you two standing the left main LAD?
Yeah, I prefer the second one. In our daily practice, I prefer the simple for putting the professional stance, and then another DCB could be applied. Then, as we appreciate that ostial RCX is supposed to be safe, to be not really wonder whether the shifting part could be happen. Then we might reassess using the OCT whether there will be disturbance of flow in circs. Thank you.
Okay, how about Dr. Ismir? Do you do any difference?
Yeah, I think that I'm one of the physiological believers. So if there is no evidence of ischemic, I will not touch the circ. So I will follow the rules that make it simple, that maybe only left main to the LAD, otherwise hybrid with the DCB in the mid part, if it's okay, and leave it just simple like that. And I think that the 210 strategy is just bail out in this case. And I think that what Dr. Noriaki rescoring about the side brain compromise might be calculate that the score is low in this case because based on the data from the OCT shows there's no huge score that might consider for the carinassive, even the left main is quite short. That's all, Dr. Fauzi.
Okay. Dr. Nanda, so there is a controversial comment. So
Yes,
what you
Dr.
did
Fauzi.
actually, because whatever
Okay.
the operator did, there is another opinion from other operator as well. Yeah.
Okay.
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 Please,
Shall I
we
continue,
are
Dr.
looking
Fauzi?
forward. Yeah, we are looking forward.
Okay.
Sorry, there is a beyond the schedule for your bear with
Okay.
us.
Sorry.
We
Sorry.
add some more minutes. Yeah.
Okay. Thanks, Dr. Fauzi. So our planning, I tend to make it more simple. I mean, my principle is to do KISS, KISS, keep it simple and safe. So based on the FFR and the OCT findings, we opted for provisional left main LAD strategy using the hybrid approach, which is left main to proximal LAD, and the distally we will put the DCB in the mid LAD, and we are considering not to touch the circumflex despite its appearance on the OCT as the FFR was negative. That reassuring me at that time that the flow remained preserved despite the you see the calcium and the stenosis in the circumflex and the OM branch. So the lesion preparation will be balloon-based strategy, no debulking device or no atherectomy or whatsoever. Then
So, yeah, please share. Please share.
Okay.
Yeah.
Okay. Then as we saw the lesions morphology in the left main to proximal LAD, we were mainly consist of the fibrolipidic lesions. We started to do the predilatations with NC balloon 3.0 by 15 millimeters along the LAD to left main. And after the first predilatations, I think we can notice here together that there was a non-flow limiting dissections in the diagonal branch I was quite frightened at that time. Therefore, we decided to protect the diagonal branch with a wire before the diagonal branch is further compromised or closed, even it will cause us so many trouble later on. So then we try to deploy a Science Zera 3.5 by 23 millimeters from the left main ostium to the proximal LAD, as we know that there was no clear landing zone at the ostial LAD. Also at the left main, there are also some kind of diffuse disease and diffuse fibrolipidic lesions along the left main shaft, I think. So we put the stent along the left main to the LAD. And we did a POT along the left main with 4.5 by 10 millimeters pod balloon, which has two short shoulder at the proximal and the distal edge, which is protecting the anatomy of the carina on the bifurcations. So this is the post left main LAD stenting angiogram. After we deployed the stent, it looks good angiographically. And of course, we can still see some residual stenosis at the distal of the stent, as we haven't touched the mid LAD yet. Again, we perform the post-OCT, post-stenting OCT, I mean, to make sure our stent is optimal. There was no medial dissections at the LAD. The stent was quite well opposed in this LAD area. However, you can see from this view, closer to the left main, the contrast clearance was suboptimal in the left main area, which is most likely due to the short left main here. And we can see clearly the stent expansions or the stent tend to be malopposed in the left main area. To solve this problem, we proceeded with further predilatations, further post-dilatations. I mean pod. We performed pod with the 5.0 by 10 millimeters pod balloon in line with the left main dimensions, actually based on the OCT. And as we know that 3.5 diameter Science Zera can be expanded up to 5.25 millimeters. And then we reassess whether the left main LAD PCI alone was sufficient to restore the flow in the LAD and relieve the ischemia by doing the repeat FFR. However, unfortunately, this was not enough. The FFR remained positive, only increasing slightly from 0.71 to 0.75. And you know that this really supports that it is difficult to achieve an optimal PCI result in diffuse disease. So yeah, again, I will let Dr. Fauzi and the panels to discuss the case.
That's good. Considering the time limitation, we were looking forward to what your next strategy.
Okay. Shall I
So
continue?
you're already putting the stent to left main LED,
Yes.
and then evaluate using FFR, but still there is a
Yes.
significant. So what
Yes.
would you do? Whether you are putting the stent or the distal part, another overlapping stent to the distal part, or would you have any other strategy?
So
Yes, please.
yeah, this is what my strategy is. As the post-stenting FFR remained positive due to the residual stenosis distal to the first stent, we proceeded with the predilatations with the 2.5 millimeters by 15 NC balloon distal to the first stent, and then we continued with the cutting balloon, also 2.5 by 20 millimeter. As we know that from the OCT, we know that the mid LAD is about 2.5, around 2.7 or 2.6. So we a bit decrease the size of the balloon and repeat the angiogram to make sure about 10 minutes to make sure whether there's any recoil or the acute closure of the vessels. So as a hybrid PCI with DCB had been planned before, we repeated the FFR before we deployed the DCB. And you can see that this time the FFR was so much improved. It's from 0.75 increased to 0.86, which is considerably clinically acceptable. And then we proceeded confidently to deploy the new sequence 2.5 by 25 millimeters in the mid LAD according to the OCT findings. So this is the final angiogram result showing telemetry flow, although there's a clear non-flow limiting dissections in the mid LAD and also the diagonal branch. At least the diagonal branch are preserved, still there. Diagonal 1, diagonal 2 are still there. Therefore, we concluded the procedure at this stage, Dr. Fauzi. And yeah, because of the high-risk ischemic, we give the patients antiplatelet for 12 months, increase the dose of atorvastatin to 80 milligrams once daily, and then we try to achieve the lipid profile target by rechecking the lipid profile after 6 weeks after the PCI. That's it. Thank you, Dr. Fauzi.
Thank you, Dr. Nanda. Very advanced strategy in dealing with such challenging cases, a very tough case actually. And if you are manage a misstep in this kind of situation, there would be potentially fatal complications, including close the side branch. There is too many branches in the LED, and of course the circumflex as well. So, Dr. Noriaki, would you do difference with Dr. Nanda did?
Thank you. Firstly, thank you for the good presentation, Dr. Nanda. So actually, that was so complex scenario PCI. So if my procedure is based on the FFR value, I will do the same. I think. But if my procedure is based on the angiogram, so probably I will not do the I will not touch the mid part of the LAD. Just put the stent and just optimize the stent position, and I will finish the this session. And but we will need a close follow-up for the patient about their symptom, and also we need to do our optimal or medical therapy for this kind of patient, I think. And I have one question. So patient have a belly diffuse disease, and and left circumflex has a intermediate stenosis, no functional or ischemia. So, how do you keep the future potential of left circumflex PCI? In this kind of scenario, do you routinely perform the KBT for keeping the access for the future PCI for the left circumflex?
Okay, interesting questions. As we know that Dr. Nanda didn't do kissing balloon inflations, how you respond to this kind of questions?
Yeah, thank you, Dr. Fauzi. So yeah, we didn't do the kissing balloon technique in this kind of procedure, but I think by doing the 2 times pot in this kind of procedure with the 4.5 millimeters and also by the 5 millimeter diameters pot balloon, I think we should open the strut a bit to make it easier for further interventions if needed to the circumflex artery, I think. Yeah, that's my answer to the Fauzi.
Yeah.
Okay,
Thank you.
so yeah, unfortunately there is a short left main, so we are going to have such a quite difficult, but we can identify there is a wide opening of the circumflex as well.
Yes.
Yes. Okay, any question from other panels or other comment, please? Dr. Ilham, Ismir.
I think that what Dr. Nanda did is very great, especially that he used a dedicated pod balloon. That right? Is that right,
Yes,
Dr.
yes,
Nanda?
it was, Dr. Ismail. Yeah.
Yeah, it's dedicated pod balloon, but daily in our practice we in Indonesia didn't have that kind of dedicated pod balloon, but that ones that make sure that the opening of the circ will be much more achieved rather than do final KBT. What I would like to answer, did you also do a gain assessment of the physiology to the circ after the PCI left main to the LAD, Dr. Nanda?
Actually, we didn't perform the functional assessment to the circ after we did the PCI. Yeah.
Yeah, maybe by the angiogram there is no compromise of
Yes.
the OCT of the circ. Okay, I think that's enough for me Dr.
Thank you.
Fauzi.
Thank you, Dr. Ismail.
Okay, how about Dr. Ilham? Would you do difference?
It is almost the same, I think. But the concerning about the stent expansion, because not every centers have the good stent. But for when we do for the left main PCI, we think about the PCI left main is need a bigger stent, so we need thinking about using NC balloon, short stent balloon, as we need the size as precisely with the left main size. And sometimes we're thinking about there is discrepancies of the size of the proximal LAD with the left main. So we must have a table of the maximal expansion stent for the when we want to putting stent from the LED to left main. So why every center sometimes needed must have a table of the maximal expansion stent before we putting stent in the LED to left main, because sometimes if there is more than table, sometimes we afraid of the fracture of the stent and it's very danger for the left main posture. Thank you.
Yes. Any comment from Dr. Nanda?
Yeah, I think it is a very important comment by Dr. Ilham that we should also know our stent expansion rate, especially in the left main positions, so that after stenting or after doing the pod, the stent wouldn't shrink because of overexpansion, especially at the proximal part of the stent. So in this kind of procedure, I put 3.5, and I know that this kind of stent, Giant Sierra, can expand it very well to the 5.25 millimeters. So it should be safe if we expand the stent to about 5 millimeters according to the OCT measurement. Thank you, Dr. Fauzi.
Okay, thank you very much. It is we are approaching the close to the sessions. So we have gained a valuable insight about OCT and FR. Let me summarize the key point. First, OCT acts as a guiding lens for the modern interventional cardiologists, as you can appreciate from what Dr. Noriaki and Dr. Nanda cases. Instead of blind decision making, they make OCT and FFR to guide the strategy. So OCT and FFR are extremely helpful in formulating strategy and optimizing bifurcation PCI procedures. From Dr. Nanda insightful case, we have learned how FFR OCT can be a beneficial tool in managing complex cases. Of course, OCT is not magic wand. Its application in PCI require adequate technical skill to ensure good acquisition, interpretation, and appropriate response. So on behalf of Indonesian Society of Interventional Cardiology, we would like to express our gratitude to all faculty members, Abbott Indonesia, and the entire organizing committee. Thank you for your participation. See you in the next session and stay healthy.
Thank you, Doctor.
Thank you.
Thank you, Dr. Fauzi,
Thank you.
Yeah.
Ilham, Dr. Ismir, Dr. Noriaki,
Bye-bye.
Dr. Saifur.
Bye.
Yeah.
Thank you.
Bye. Keep in touch,
Bye.
everyone.